Ellie, Ellie. Hello. Can you hear me well? Yeah. Okay. Is it afternoon there? Yes. You can speak.
Oh, really? Oh, okay. Are we? Oh, I see. Oh, I thought we were doing the like 3 minute thing. Okay.
Oh no, I never
Okay.
do that because this is much more easier and then yeah.
Okay. Yeah. Fair enough. Okay. Easy peasy.
Uh-huh.
Is everything good on your end?
Yes. I just wanted to ask, like, I know that when I was searching for your name on Facebook to just like make sure about the time, I ended up on your profile. So do you have a twin?
Yes, I do. Yeah. Yeah.
Yeah.
Yeah. Yeah. Yeah. Yeah. Yeah. And he's on the platform as well. So, um, yeah, yeah. So we would be fairly similar. He's got shorter hair than me though, so it looks slightly different. But yeah.
I also have a twin, so
Oh, are you identical or fraternal?
no, we're not identical. I wish we
Okay.
were.
It's all right. It's okay. Um, okay, great. Well, we've got 43 and a half minutes. So, since it's your motion, why don't you start off?
Okay, great. So the motion is assisted suicide should be legalized. So
Yep.
when I say this, I do definitely have certain limitations on what I want to present as a pro in this case. So assisted suicide, let me just start by defining the key terms. Assisted suicide would be something that is committed with maybe aid of another person, sometimes a physician, and then a doctor maybe knowingly and intentionally providing a person with knowledge of means or both required to commit suicide, including counseling about lethal doses of drugs or prescriptions. And then in which kind of conditions of a patient, so only in terms of the terminal illness, so maybe terminal illness is in an incurable disease that can be treated and is reasonably expected to result in the death of a patient within a short period of time. So that's what my case seems like. This two would be the main factors I'll be evolving around, helping dying with the help of a physician, and only in case of a terminal illness, not necessarily for everything or maybe whenever you want to die. So that's what kind of something that's kind of something I want to argue as a pro in this debate.
Okay. So firstly, like assisted suicide as someone committing suicide with the aid of another person, whether materially or in terms of provision of information. That seems fair enough. Just on the second thing, so you talked about the condition being terminal illness. So you would exclude, for example, someone with locked-in syndrome, so a disease that isn't terminal but reduces quality of life to the point where a reasonable person might consider suicide to be a legitimate option. So you would limit it specifically to people that are going to die at some point in the future. Is that where you're coming from? So like a fairly limited
Yeah,
definition of it?
I do agree. I mean, like, I do get what you're trying to say. So not, as I said, like, but not necessarily like so strict on this idea, because I know that when I'll be arguing on this motion, I'll definitely have the quality of life as one of my, like, arguments. So that does not necessarily have to be just people from terminal illness, but maybe like whose suffering is extreme, like, not necessarily even, maybe even if they're not dying in a certain period of time or something, maybe it's not expected, but still, if in case the condition they are in is like extremely difficult, like, then I definitely consider it. But then, well, I do it. Definitely, we do have some confinements within how this is made, like how this is actually going to be conducted in practically, like, So it's not something that you just, if in case you feel like, hey, like I'm in a terminal illness, or maybe like I'm extremely unhappy, like let me just go ahead and suicide. So this is not actually how I would suppose it works. So there will be definitely mandatory state reporting, maybe by the medical team. There will be medical board oversights. There will be doctors and witnesses who would actually attest to the condition of the person. And there would be psychiatric evaluations, whether the person is coerced to this, like, or maybe forced to this, or is actually willing to do this. So there will be a lot of this kind of methods in terms of practicality of this assisted.
Okay, yeah. But so we'll just take kind of as the way to debate it. So maybe it just might be a bit easier. So we'll be a bit kind of loose on the terminal illness part. But then I think both of us can be reasonable in sort of saying, like, this isn't going to be like you can rock up and say, oh, doctor, I'm really upset today. I want to kill myself. And then he gives you like 20 grams of cyanide or something. Like that's not what it's about. It's actually about there being a reasonable process. And I agree with that. So I think that's pretty fair. Cool. Okay. Yeah, no, that works for me. Easy. Okay. So most of my arguments are basically responsive. So if you've got stuff to start off with, maybe you could start and then we can kind of play with those ideas for a bit.
Okay, great. So I think death is death or maybe pain is definitely an intimate event for anyone's life, and then so it's a kind of like a horrible form of suffering. And let's just like give an example of maybe maybe some people like actually referring that I don't want to live in this hospital bed for like, maybe next 3 years or next 3 weeks waiting to die. Like, if in case I have so much of pain right now, I would rather, if in case the pain, and especially the pain, if in case is not supposedly getting to like, go away from them, so I know that I'm not explaining this properly, but the thing is that there are times like when those kind of pain maybe not have very less possibility or have zero possibility of actually getting away from them. So the only way they could actually get out of it would be death, so that's also kind of like in terms of suffering, that's also what I want to refer, like when they do not have any other option of like throwing off their pain or maybe getting out of it. So maybe in that case, like, I think dying should not be completely separate from everything else one does in medicine. It's also a part of medicine. And so I think it also gives a person a sense of autonomy when they feel that they have a control in it, no matter. So even a result of the hospital actually shows that even though you are prescribed to do assisted suicide, like if in case you want to do it, you can go ahead with it. So even though people had prescriptions, they not necessarily actually jumped into it and then did it. Like, it's just that the people were relieved that they knew they had a control in it if in case they ever wished to have it. So, that's also kind of another relief one gets. And secondly, the person who actually chooses to be a part of it would also be in a way of relief if in case we see it. So assisted living, assisted suicide, if in case we see it, the major causes of those kind of cases would be when people actually feel that they do not have a control of their life, or when they realize that they're losing the quality of their life. Or I actually had an exact thing here. So yeah, so that's when people actually choose to get into this idea of assisted suicide, when people know that they have very less control on whatever they are doing, or maybe their personal living condition or their health ethics is actually not as much as they want. So I think that's when a person decides to have this, if in case we see just like generally, and then we know that they are not liking the dependency they have on other people as well. So assisted living is far harder than assisted death. So that's the kind of mentality I think that's created between those people. And then yeah, I think assisted suicide is lets you choose. Like, most of all, like when I say it should be legalized, I'm not saying that it should be promoted or it should be something that should be necessarily done, but it's just that you're giving an option to someone, and then that makes a lot of difference. So that's something, that's something I believe.
Okay, great. So we've got two ideas there. So the first of which being that in some instances, there's no option to escape pain outside of death. And the second of which is that we can give people a sense of autonomy and control over their own lives at the end of life. And I think that both of those are fair points. So on this, I think that these are both interesting arguments. And the thing about the euthanasia argument or the assisted suicide argument is that it's one where the grounds have shifted radically over the last 10 years because 10 years ago, the science of pain management was much worse than it is now. And the prerogative of doctors was generally to extend life as opposed to enhance quality of life over the point at which you are alive, right? So if we'd been having this debate 10 years ago, then absolutely I would be on your side because there wasn't really a mechanism by which someone was able to say, no, this is intolerable. I wish to end my life. Or like, no, this is intolerable. I would rather feel better than live longer, right? And so on the first thing where you said that there are some instances there are no options to escape pain, that's just not true anymore. And the reason it's not true is because in the past, under the paradigm where people had to, where doctors were required to try and extend life as long as possible, that meant in lots of instances ignoring practices that would allow for pain minimization. Now we've flipped that, and so people are able to improve quality of life. So, for example, if you're a cancer patient, there are lots of treatments that are exceptionally painful and exceptionally uncomfortable, right? Now, 10 years ago, the standard assumption was that you would continue those treatments up to the point of death, even if it meant for an exceptionally unpleasant death. Today, what we're much more likely to do is allow patients the choice, not between dying and living, but between how they spend the rest of the time in which they are alive. So you can either continue your treatment or you're able to have pain mitigation strategies and quality of life enhancement strategies put in place, which makes it much easier for people to enjoy a higher quality of life. And in some instances, actually, it means that they end up living longer than they otherwise would have because, lots of cancer treatments, for example, are really, really invasive and really difficult to endure. So what I'm basically saying here is that if the dichotomy is between being in pain constantly until the point where you die and dying early and not suffering that pain, then that would be a fair point to make. But that's just not true anymore. Now we have another option, which is that you're able to live the rest of your days in comfort. You're able to, spend that time with your family or your friends. And then at the point where you would die naturally, you do die. Now, let's keep in mind here that paradigm is so advanced at this point that if the treatment required to provide effective pain relief killed you, then that is something doctors are prepared to do. So, for example, like morphine is the most effective painkiller that we have, right? Opiates are the most effective painkillers that we have. And the reason in the past that people weren't able to get effective pain relief is because the amount of morphine required to effectively combat pain levels would be enough to lead to an opiate overdose and the death of that person. Currently, it is morally acceptable and legal to provide what a doctor will know is a lethal dose of morphine so as to ensure pain relief. So, functionally, if your central argument is that pain, in some instances, like that life might not be worth living, we have changed the way that we conduct medical treatment. And as a result, we are now able to allow for a higher quality of life. That means that the kind of scenario you're talking about isn't possible. And just to be clear, there's a big difference morally between a doctor carrying out pain relief and a doctor actively leading to the death of a patient. That's something that's morally difficult for lots of doctors. It's also something which has like a series of second order effects. So I'm going to talk about that a little bit later, but let's just acknowledge now that what I'm talking about isn't ignoring the pain of patients. It's dealing with that pain and that discomfort at all costs, and recognizing that there are options outside of euthanasia or assisted suicide that get basically the same results, what you're talking about, but without any of those second-order harms that we're able to observe from places that have had euthanasia legal for a long period of time, like some countries in Europe. The second thing you said was that there was a sense of autonomy and that we can provide a sense of autonomy for people. And I suppose that here, the first thing to say is that that sense of autonomy is important mostly because you're talking about an instance where people have they have a really low quality of life and they're unable to do anything about it, right? And the sense of autonomy would come from being able to do something about improving that quality of life. As I've just talked about, it's now entirely possible to allow for that quality of life to be enhanced, and we give patients the option to choose whether they want to live for a possibly longer time and have a lower quality of life, or have a higher quality of life and live for a possibly shorter period of time. So the kind of autonomy that you're talking about is something that we are able to provide in other ways, again, without forcing suicide or without someone committing suicide. Generally speaking, we allow people to make choices about their quality of life up to the point where they intentionally kill themselves, right? There are some instances where people would imagine that their quality of life would be better if they were to commit suicide. You know, in the event that someone is attempting suicide, it is the prerogative of everyone around them, including all state actors, to attempt to prevent that suicide, right? This is a particularly unusual kind of autonomy in that we recognize that life is generally more important than autonomy in this specific instance. Now, because we're able to deal with the specific problem that would make this different from other instances, that is to say the exceptional levels of pain and discomfort that patients might face, it becomes similar to other instances where we would be discussing suicide, at which point we would not consider their autonomy to be paramount above the assumption that life is worth living. So I would say that on those two things, there is a better option available. It is one that is useful. It's one that didn't exist in the past. And it's one that's able to get the kind of outcomes that people that support assisted suicide would want without any of the harms. And in fact, in lots of instances, you know, like if you're someone that's on really heavy chemo and then you go off it, right, you're going to have another couple of weeks or a couple of months of living, which are going to be a much higher quality. You might, in the midst of engaging in chemo, think that assisted suicide is the best option. But in many cases, it turns out that taking the risk, going off chemo, beginning a strong pain management plan actually allows for periods of time that are of a really high quality that weren't considered at the point where most people would be talking about wanting to engage in assisted suicide. So yeah, so back to you.
Okay, great. So when you talk about the idea that you are providing a better quality of life now, I can hear myself speaking. Okay, this is bad.
I can hear you fine. Yeah, I can hear you.
So like when you talk that the quality of life is actually being increased, that's something I do not agree to, because when you are using palliative care, when you are using painkillers or maybe prescriptions to do that, you are actually prolonging the suffering of the person. Because as I said, I'm not just talking about a normal illness here. I'm talking about something that's that is very near to incurable, or maybe that is actually reasonably expecting to cause the death or extreme kind of suffering. So in that case, if you see that it's not necessarily, as you advocate, it's not actually increasing the quality of life, and it's a palliative care. Maybe you'll be using painkillers to reduce your pain or something. You'll be maybe extending your life, but still this is a prolonged suffering, because you know that there has to be an end, or there is no proper solution to it. So even though medicine has brought greater benefits to humanity, and it cannot entirely solve the problem and the pain and distress of the dying process, or maybe of the painful, extremely painful process which I'm proposing. So this is something that the quality of life is not actually assured when we say that maybe now medicines have actually done a better job at it. It's still not done, because as I said, palliative care or maybe painkillers or those kind of things are not supposedly doing that. They're just extending the suffering. Secondly, when you tell us that, so maybe if in case a person has a cancer, like the person would be provided with options that, hey, like if in case you take this kind of prescriptions, you might be living 2 years longer. And if in case you don't, like, you could just die, like, maybe within months or so. So I think even in this case, there is definitely a decision for the person for the person, like, the person has the right to make a decision whether or not the person wants to take prescriptions on it, whether or not the person wants to actually take life 2 years maybe ahead of it. So I'm just arguing on the same idea. Like, we just have to give the person the choice to die as well, if in case the person wants to live. So if in case we are giving the option, we are giving the person the option to extend his life, I think it is very when you talk about autonomy, I think autonomy also includes the idea of giving that same person the right to die, because if in case you are putting two options of whether or not the person wants to extend it or just leave it the way it is, like, I think we should also give them the option to die, exactly as the way you propose autonomy to maybe live 2 years longer. So I think a lot of, and in this case, if in case we see sometimes maybe even financial matters come a lot into concern, whether or not a person gets to extend his life or not. So I think in this case, I think we should also keep in mind those kind of people who are actually maybe sometimes, I know it's also about willingness, but maybe even in terms of like financial matters, if you see some people are not necessarily adequate enough, they don't have they're not able enough to actually pursue this. So I think even in that case, you're limiting those people's autonomy to actually make a decision for their life, and that also counts here. And
sorry, just on that, do you mean that people wouldn't be able to afford palliative care, or people wouldn't be able to afford medical care for a long period of time?
People would not be maybe, the thing about extending life, maybe for 2 years, the prescriptions that helps them live maybe 2 or 3 more years for cancer, or maybe anything like that. So
So people wouldn't be able to afford the treatment for a long
exactly,
period?
yeah, that's also something.
Okay. Yeah. So just on that, and this is kind of, I'm sorry to interrupt you, but this is just like a definitional sort of thing. So that is a question which I wouldn't really like to talk about, because it's a question that is different contextually in the country that you're debating in. So like, I'm debating in Australia, that's actually not a consideration, right? And that's not a consideration if we were having this debate in the UK or in most of Europe, or in Canada, it wouldn't be a consideration. Obviously, in the United States, it's a kind of contextually difficult question. Like, if you're someone that has really good health insurance, it's not a problem. Yeah. So it's one of those things which I suppose if you really want to talk about it, we could, but it's kind of not universally applicable, whereas the rest of this debate feels a bit broader. So like, if you want to have that discussion, we can, but it's a bit tricky because it's talking about less the like principled thing and more the anyway, so I'll just let you keep on going, but I was just going to make that point. That's a bit of a tricky kettle of fish to open. Okay. So yeah, sorry about that.
That's right. And I think so I actually maybe to question you on the debate, like, why do you think there should not be an option? Because as I said, we are not forcing this to someone. We are not necessarily telling that, hey, like, you should do it anyway, like, so why don't you think like there should be an option? Because even though, like, you say that maybe hospitals are actually giving you better care now, but still, like, why does that necessarily stop a person from having an option of dying? Like, I know that they if they have a better option of living a good life or better life as you propose, why should they be maybe abandoned from the right to die as well? Like, why should we not give them this right? So I think I'll just give it back to you.
Okay, so we'll just kind of go backwards from that. So firstly, why should there not be an option? So there are a couple of layers to this. The first is that generally we don't give people the option in the event that intervention exists, we don't give people the option to commit suicide. And what I mean by that is that we don't say, like, if someone, is about to jump off a bridge, right? Like, and someone's walking past, you don't go like, hey, dude, did you think really hard about this? Like, are you sure you want to do it? And then the guy goes, yeah. And then you go, oh, okay, like, sure thing, buddy, you do you. Like, we don't actually look at death like that, and we don't look at suicide like that. We look at suicide as something which is to be prevented and something which is to be forestalled. Now, the reason that I can understand, and that's just a kind of broad principle that most people would accept, if there was someone that was about to commit suicide, you would attempt to intervene and stop them because you would understand that their right to life and it extends, and the kind of passing moment at which they might want to commit suicide is more important than their autonomy at that moment. Now, the reason that it might be slightly different in the instance of euthanasia is that these people are already under substantial pain, to the point where life might not be worth living, and a logical person would consider that. And the contention I would make is that palliative care is good enough that you are able to get rid of pain in the way, in such a way as to mean that they would have a similar quality of life, not to the average person walking around, but to all sorts of people who we would consider it unreasonable for them to kill themselves. The second reason that we don't necessarily have to give them this option outside of that is that we're talking about assisted suicide. We're not talking about suicide full stop, right? It requires the assistance of someone else. And I think that for a good number of reasons, it is a bad idea to suggest that people should have a responsibility to assist in the suicide of other people. Let's keep in mind that the people that would be assisting with this suicide are health professionals. This would violate, in a really profound way, their code of ethics and the way that they would consider their role as medical practitioners. It would also likely be quite traumatic for quite a few of them, right? It would also possibly shift attitudes around assisted suicide in a way that is really, really difficult, and in a way that leads to future harms that we have not considered. So, for example, so both of us agreed that we would limit this debate to be something quite small, right? And that's the way that most euthanasia laws, when they are initially passed, pass. Now, the reason that you're able to get future harms that are more substantial is that in the event that you shift a medical professional's remit from preventing death and assisting in facilitating in a higher quality of life, which is what a medical professional's current job is, to allowing the patient to exercise their fullest autonomy, even to the point of death, that shifts their role inside the medical profession and shifts the way that people conceive of them, particularly policymakers. So basically here I'm making a slippery slope argument. And usually I don't like slippery slope arguments, but I like them in this case because we actually have really, really good examples of slippery slope cases already occurring in ways that we would consider to be really abhorrent. So for example, in Denmark, I think just last year, someone was had a medically assisted suicide because they had a profound case of depression, right? Assisted suicide or euthanasia would normally be considered something that's quite unusual. What we've seen in countries where it has been legalized, particularly in mainland Europe, in Switzerland and Denmark in particular, which are the two countries that have had assisted suicide for the longest period of time, there's been a steady creep because instead of there being a really strong barrier where like a medical professional's role is to prevent death and assist in facilitating high quality of life, that barrier has changed. And there's really very little difference between, for example, someone who is terminally ill and is going to die in 6 months and someone that is terminally ill and is going to die in 7 months. And then there's a further lack of difference between 7 and 8 months, and 8 and 9, and 10 and 11, and so on and so forth, right? And that makes it really difficult. When you shift the principal boundaries from one thing to another, you make it really, really difficult to defend against future legislative efforts and future kind of creep of these kinds of harm. And that's something which is really dangerous and really difficult to ameliorate, right? Again, I don't normally like slippery slope arguments, but the reason that they're relevant in this debate is that we've already seen this happen, and we've already seen the progression and the shift of doctors' roles in a way that is really, really damaging. So to just go back to the original thing, you said, why should there not be an option? Basically, because with palliative care, we're able to get to the point which is quite similar to the average person's quality of life. And so at that point, it becomes just like a normal suicide, which is something that we wouldn't accept. And then the second reason, if you don't buy that, is that there's the potential for quite substantial future harms and a degradation of the role of medical professionals. And just here, before I pass off to you, I just make the point. So you said earlier that there are no options in some cases to escape pain except death. And you said that, you know, if you're terminally ill, then euthanasia or assisted suicide would be important in preventing death. In preventing pain. And so here I would say, as I said earlier, that morphine will cure your pain at some point, right? The reason that sometimes it's been ineffective at that is because the amount required is higher than a lethal dose. As I said earlier, if you say to doctors that their job is to minimize pain as opposed to prolong life, then that means that they are empowered to give a dosage above that would trigger an overdose that would kill them, right? Now, I would say that is not problematic because the role that they are carrying out is not assisting in suicide, but assisting in effective pain management. And as I said earlier, the real danger here is that you shift doctors' roles in a way that's really, really dangerous, right? And I would contend that this doesn't do that at all because they're actually carrying out their core duty of allowing for a higher quality of life for patients. So essentially, the way I see it, there are no harms to allowing doctors to prescribe effective pain management because they're able to do it in such a way as to effectively lead to a higher quality of life for that person. But there is the potential for really substantial risk. And I think that that's something that's quite dangerous. I think it's something which in other countries we've seen happen. And I think that that's something which is important to recognize and be very careful about.
Okay. It's my turn.
Yeah. Sorry about that.
I'll actually definitely get into the health professionals as well. And I think the role you have characterized as a medical personnel is very big. And then I think that's not actually how it works in the real world. And just starting from, let's see, like how people reach to this kind of suffering. So in record, like in the survey that was conducted, or I think the reports from the hospital that says a person actually reaches to this point of maybe suffering or this point of terminal illness when the person feels that there is very decreased ability to participate in activities that made life enjoyable, and very less decision making and for themselves. So these are the kind of like areas when a person actually decides to maybe apply or maybe prescribed by assisted suicide. So this is something that is not going to be cared or maybe looked after by a palliative care, because as I said, it's just reducing the pain. It's not necessarily assuring your ability to participate in activities that makes life enjoyable, or it's not necessarily giving you the autonomy of controlling your life or maybe giving you the decision-making power. It's just taking away your pain, and that does not necessarily match up to the reason why this thing is happening right now. That is one thing. And then secondly, there was a thing about, okay, where did it go? Okay, the idea that, like maybe it does not fall under a medical treatment or medical oath, like it has some moral ethics and everything. But the thing is that if in case we see in record, the original oath that has been taken by medical professionals has been modified many times, and contrary to popular belief, like it is not even required by most modern medical schools today. So this is something that is that, as I said, like we assume that there's something people have followed, or maybe medical schools or medical treatment has followed, but not necessarily. The oath actually has been modified, and even in terms of like has been actually held contrary to popular beliefs, and then it has actually ranged beyond what we are thinking it has. And then I think what I want to argue on this is that, so health professionals, their role is just to suggest us. I think that's where their limitation is. They do not necessarily feel I think they do not necessarily feel accountable for maybe creating or maybe helping someone die, or like not necessarily do, or maybe just a second, I just so just to create a difference between euthanasia and assisted suicide, I think there is a difference between euthanasia and assisted suicide, because euthanasia is more about directly involving in the act of maybe using the drugs or maybe killing someone if in case necessary. But assisted suicide is more about the doctor knowingly and intentionally providing a person with knowledge first and giving the person the option whether or not he wants to do it. So I think there's a bit difference in euthanasia and assisted suicide, and it definitely includes a lot of counseling, a lot of talking, a lot of like, a lot of data, a lot of those kind of ideas to maybe incorporate whether or not a person has to go through assisted suicide. So it definitely does make a difference. And so when you say like we definitely stop someone from doing a suicide, like so here like we are so I think there's a certain difference between a person jumping off the cliff and then a person who's actually choosing to have this decision of assisted suicide, because as I said, there's a lot of counseling and there's a lot of thinking put into it. So it's not necessarily something you just do it quickly in pain, or maybe whenever you're in pain, you know that there's something that you don't have an option of, you just jump off the cliff. So I think it's very different in this case here, because it's well calculated and then well formulated before actually, like being done. As I said, the practice would definitely get into a huge area here. And I think, so if we see like, the degree to which physical pain and maybe a psychological distress can be tolerated is different on all human beings. And then quality of life judgments are private and personal. So only the sufferer can actually make relevant decisions, not even the doctor. And so if in case we see doctor so responsible, I think like whenever they I think their main role is just to suggest if in case we see or maybe perform what the patient wants. It's not necessarily they never can actually get beyond what the patient wants them to, wants from them. Because again, I don't want to bring the financial constructions thing here, but like, it's it just jumps in. So, I think their role is very limited to suggestions. Their role is very limited to being the best form of advice, but not necessarily implying it, because as I said, quality of life judgments are very private and personal, and then only the sufferer is in a position where he can make relevant decisions. So I think it's important. And what I as a prop would want to argue is that, like, I think it's very important that we have the right to control the time and the manner of our death. And I think it makes it brings a lot of easiness, and even in terms of how we see how a sufferer actually sees death, because I think that in a way it would increases maybe would actually, like, maybe he could actually do whatever he wants to before he actually dies, or maybe the idea that it just I'm not getting it properly, but so I think it creates a lot of difference, that you're giving someone a control of their own life, and you're not necessarily advocating it. You're not necessarily like going out and saying that you have to do it like compulsorily, but you're just giving them an option. And I think and humans, we know that we love having autonomy. We love having control on what we do. We love having control on our life, and that's I think that's, in fact, that's actually something that is more essential in a human being, because as an individuals, we're always striving, like, to be maybe a unique individual or better, or like having a control on our lives, just being able to decide what we want in lives. So I think that's something we enjoy biggest, like in a huge manner, is our personal autonomy. And I think that's something that should be provided to a person who is suffering a lot. And it definitely ranges beyond medical professionals, because they are there to help, they are there to suggest, but they are not necessarily the sufferers, and they are not in a position of making relevant decisions for the sufferers. And even in terms of the medical oath or treatment, it has been something that has been revised, that has been moderated again and again. So, and even like, a lot of medical schools or a lot of medical treatments actually have been happening. So even in Oregon, I think there's a 20 years law of this, assisted suicide. So there's never been problem of the violation of, I think, medical ethics there as well. So it's just something that has to be definitely regulated in a proper manner, but it is something that is definitely moral, that is definitely acceptable. And it's it's not saying someone to go ahead and then die. It just like, giving them the option that if in case you are in a suffering or in a pain where you like, cannot get out of it, or like you are definitely contestable for your, like, you're definitely you definitely have the incontestable like right to die in a manner, and then at a time of your own choosing. So that's what this motion is giving to people. So I just will pass the mic to you. I spoke a lot.
Okay. No, cheers for that. So we have 5 minutes. I'm just going to try to be nice and quick so we can have a bit of time to chat at the end. So just going through the things that you said. So the first thing that you said is that people don't have the autonomy to carry out activities that would make them happy, and that's an acceptable reason to allow them to commit suicide. I would say that's not necessarily the correct way to look at it, because we already see that happen all the time, and people don't necessarily commit suicide on that basis. So, for example, if there was someone who really enjoyed long distance running or basketball, who was then placed in a wheelchair, something which they consider to be really, really important, they wouldn't be able to carry out. We wouldn't consider that a justifiable reason to commit suicide. Similarly here, like, sure, like if you're terminally ill, you might not be able to go for runs every day. You are able to spend time with your family. You are able to spend time with your friends. You are able to, do the stuff that's most important to people and most central. So I don't necessarily think that that stands up especially well, because it's not the standard that we'd use for other people. The second thing that you said was that the code of ethics has changed over time with regards to the medical professionals. So that's true, but the core of that hasn't changed since the Hippocratic Oath, which is, first do no harm. And so we'd say that, yeah, like it changes over time in relation to, in the way that all institutions and all things change over time. But you have to look at what's particularly important, the things that haven't changed, the reasons that they haven't changed. So in this instance, it's because doctors' jobs are to preserve life and then to improve quality of life. And all sorts of things have changed around that. But those two central planks have not changed for all the time that doctors have existed. You talked about the difference between euthanasia and assisted suicide. I kind of, like, functionally, there's not an enormous difference. If you provide all of the resources for someone who otherwise wouldn't commit suicide to do so, there's very little difference between if you push the button or if the other guy pushes the button. Like, I suppose there's probably a slight ontological difference, but I'm happy to debate either one of those. I don't particularly mind. And so then you said that, oh, well, there are like, these people will get lots of counseling and all that sort of stuff, and that'll be great. So we'd say two things here. The first is that these people necessarily can't know other options that are available to them that would be foreclosed by assisted suicide. So, like, if you're someone that has been undergoing a really rigorous round of chemo and is in a lot of pain constantly, you can't know how the painkillers would work because you haven't necessarily had the option for them to work, right? And the second thing going on from that is that necessarily people that are considering this are people that are clouded by pain, know that their time is up. They wouldn't meet the standard for rationality that you would normally, that a psychologist would normally provide to people. It would be impossible under any other circumstance to allow them that degree of autonomy. So we'd say that the counselling will always be insufficient. And in fact, you accept that that counselling would be insufficient a second later because you say that only the sufferer would be able to make the appropriate decision because only they fully understand what is happening, which suggests, given that the sufferer is unable to make those decisions by any normal metric and counsellors wouldn't be able to fully understand, that it would be impossible to come to a proper decision. The final thing that you say here is that there's a need for proper regulation. I would say that, sure, you can set up a really fantastic regulatory model today. The Danish model in the 90s was amazing, right? And it did basically the things that you wanted it to. And there were still harms, but I'm sure that you would have been happy to defend that. What's happened over time is that because of the degradation of the role of medical professionals in providing care, there has been a shift and a degradation in the way that we consider euthanasia and we consider doctors' roles that has led to all kinds of adverse outcomes that we think are really harmful. Sure, the regulation might work for a while. It will degrade over time. It won't work. I think that this is something where we are able to deal with just about all of the harms through having a really solid care model, right, which allows for the provision of pain relief up to the point that it is required, whatever that point is. And there are lots of harms that come with assisted suicide. And so I think that because we're able to get rid of pretty much all of the harms, that would come that you're trying to deal with, and there are lots of harms that assisted suicide would bring on its own. I think it's something that we need to think about. We've got like 20 seconds left, so if you want to hurry
Okay.
finish,
The one thing I
would
would
make
say is
sense.
that when you say that maybe when we extend lives or maybe provide better quality of lives, maybe a person would get more time to spend with his family, and that's how we do increase this quality of life. But I'm not arguing that it does not, but I'm just arguing that we need to give them an option whether or not they want it, whether or not they actually want to maybe spend the time with their family, just providing them an option. So if